Hello, everyone. Welcome to another Rabih and Reza. We are super excited today for our discussion. Reza, it's been a while that he didn't join us, and so we are happy to have him back. And before the episode starts, I want to announce that tomorrow we are gonna have internal medicine residency program with us, and I want to invite you all to join us. We'll be at 4 p.m. AST. We are going to have a super cool case, and in the end, we are going to ask questions about the program, the city, the food, and will be a lot of fun. So yeah, I hope to see you all there. Rabih, how are you? Good
I'm good.
morning.
I'm really excited for it for so many reasons. I think every time that Mark has presented a case, we've all been just in awe, finding our jaws falling to the ground. So that is a very special treat for anybody, but especially if you're applying this year, you essentially have a juggernaut of a program, one of the most powerful, famous, and really well-respected programs joining us. You may not be applying there, and even then, I think it'll be very relevant just to get a sense of what the culture is like, and get a vibe for the place. But I told you all Prof. Rez is going to casually stroll in with some coffee, and look at that. Look at that. It's
What's up, bro?
hello. So Prof. Rez has been calling me bruv all morning long. What inspired this change, Prof. Rez?
Oh my gosh. So, tis the season of Halloween,
Yes.
and there's an amazing show on Netflix. It's Haunting of Hill House. And yesterday they released the third installment from the same, actors and group, which is House of Usher. And in that, there's a UK individual, and he calls his friends bruv. So
Oh,
be
really?
ready. Yeah, bro.
That's
I
amazing.
really liked it. We
That's
watched 4 hours of it last night.
That's really cool, Prof. Rez. 4 hours. I watched 4 hours of the David Beckham documentary, which I
That
highly,
was superb.
right? I'm only, yeah. Wait, I watched 3 hours of the David Beckham documentary. I'm like 2.5 episodes in. And oh my gosh, like I just had no idea. I was like a kid growing up watching him. So just didn't have a sense of just the person and the suffering. And oh my gosh, it's incredible. It really is. Yeah. Yeah. Are you looking for me to transition? You did that little like pause.
Oh no, I was just seeing what your reflections were because I love that documentary. It's like there's definitely tears shed during it. It's insane to think a whole country against you and like wanting you dead and putting bullets in envelopes and sending it to you because of Simone's fall or dive.
Yeah.
He was a kid. He's 23. Like unbelievable. I mean, I wouldn't be able to deal with that kind of pressure at
100%.
31, let alone 23.
Yeah, yeah. You just turned you just turned 31, right? It's very recent.
Yeah, that's right.
Amazing. Well, we're so excited for today, in large part because Prof. Rez and I haven't done RLR together in a while. We haven't overlapped, but even more so because Maddie has a special treat for us. Not just a case, but also a little bit of a chat GPT vibe. So Maddie, I'll hand the mic to you to kind of intro what you're doing today, and we'll go from there.
Yeah, all right. Hello, everyone. I'm super excited for today. So today, in addition to hearing the wisdom from Rabih and Reza, we are going to compare their responses to Chat GPT 3.5. And this was previously done by Ravi and Francisco a few months back, which was so brilliant. And then even before that was done at a Harvard Grand Round. So it'll just be really cool to kind of compare discussions and just to kind of clarify what I've done. So I'm going to give 5 aliquots to Rabih and Reza, and I have already inputted exactly what I'm going to tell them to ChatGPT. And then after their discussion, I'll show you what ChatGPT said.
Maddie, I love that. And I just realized something, Robbie. For the next time, I'm going to give you access to GPT-4 because GPT-4 is so much better than 3.5. So we just have to incorporate that in our analysis, Robbie.
Well, Prof.
We're
Rez, I'm
not
glad.
fighting against a bet.
I know that's great. That's perfect. 3.5 is good enough. It's good enough for me.
4 is a different beast.
Really?
You'll see that when oh my God, you have to pay $20 a month to subscribe. But I will share like for clinical medicine, it's the best thing out there. It's unbelievable.
Wow. Okay. All right. Well, I'm glad we're taking on its
Yeah,
inferior.
because let me just say this really quickly, because Strong Medicine, Eric Strong, he did a YouTube video on this with Adam Rodman on like how 3.5 would get like 20% of diagnoses, but 4 gets like 60%, something like that. It's like a huge delta. It's market different product. Anyways, the stakes are higher now, Robbie.
I absolutely love that 20 to 60, huh? Okay, all right. Well, we're in good shape then for today. Might be worse the next time we do this. All right, take it away, Maddie.
You ready? Okay. So for the first aliquot, oh gosh, let me open up my notes here. All right, so the chief concern is diarrhea. And a kind of a brief summary of the HPI. So this is a case of a 29-year-old man with a history of HIV who is presenting with frequent watery stools for 4 days. His most recent HIV labs were 1 month prior to admission, where his CD4 count was 24 and his viral load was 265,000. He says that these 4 days of frequent watery stools is actually an acute worsening of more chronic leakage from his rectum. He said he had a rectal laceration and repair 1 year ago, and since that time had intermittent incontinence and pain. He was able to avoid constant incontinence until the last 4 days, where this watery diarrhea acutely worsened, which is what prompted him to come to the emergency department. He does not associate the diarrhea with any food intake, and he reports that the loose stools really have been constant over the last 4 days, even waking him up at night. And I will pause there.
Thanks, Maddie. That's extremely helpful. I just want to make sure that our scribe got everything that you had mentioned. You gave it at a really good pace. So in addition to the CD4 and viral load, he had a laceration, you said. Is this at the anus?
Exactly. And I'll share more information in the next aliquot about the past medical history. But yeah, there was basically a rectal laceration and repair about a year ago.
Got it. So I'll be pretty brief here because we're going to get more data. But I would say that the way I'm setting up this problem to solve, this is a 29-year-old with HIV. It seems like he doesn't yet have an AIDS-defining illness, who's presenting with acute onset of frequent non-hemorrhagic diarrhea, non-bloody diarrhea. That frame is really important. Why? Patients who have HIV are both at risk of opportunistic infection, but they're also at risk of common infection with increased frequency and perhaps increased severity. And with this tempo, we're going to prioritize the common stuff like viral gastroenteritis or viral enteritis. But we'll step back and also include less common etiologies, be it parasitic processes that can involve small intestines and large bowel. The acute nature of it for now at this time frame would prioritize like a viral enteritis. However, everything that's subacute has to start at some point. So in someone like this, I would have a low threshold to send for ova and parasites up front, knowing the immunocompromised status. The other thing that we have to be cautious with, and this is how the background of HIV influence our analysis of the clinical syndrome, is that this patient may not mount an immune response like a patient with a competent immune system. So when we have diarrhea, we often try to frame it as inflammatory or non-inflammatory. That's much better initial branch point than trying to say, is it secretory? Is it osmotic? Is it malabsorptive? So it's going to be really important when we get that physical exam to to help us make progress on our DDX. And then finally, the CD4 count. So once patients with HIV have a CD4 count less than 50, they're at risk for all of those opportunistic infections. Whether these infections primarily involve the lung, the skin, or the GI tract. And just off the top of my head, things like herpes viruses, be it CMV or cryptosporidium, or parasitic stuff and non-tuberculous mycobacterial, all of these things can be at play here. Robbie, anything else to add? I feel like I'm not ready yet to make a diagnosis. I have a good understanding of the problem, which is diarrhea. The next step, is it inflammatory or not? I have a good understanding of the host, immunocompromised, very low CD4 count, but I would say that I need much more data to know how sick this patient is and what my next steps are with a very low diagnostic threshold for these workup of atypical or unusual infections, not unusual infections.
Yeah, I have nothing to add. And I think that that's the challenging part about this HPI is if you're solving this case as an immunocompromised patient with isolated diarrhea, you would go down that pathway with honestly the bullet train, like really quickly and really effectively and really comprehensively. And I think the only remaining question to ensure that this is the right problem to solve is to figure out, is diarrhea the core essence of what this person has, or do they have other distant complaints, which makes it very easy to see, which makes it very easy to mitigate the significance of the diarrhea as a mere consequence of systemic illness. And so I think you just have to, you can hear, you probably listening to the patient, and they're probably imparting the severity of the diarrhea, frequent and watery, which is a clue that it'll probably end up being the center of gravity. But I think in parallel, maintaining openness to the intestines simply just sneezing because there's something else going on rather than being the actual core problem. But I'm really curious what ChatGPT has to say, Maddie.
All right, so let me go ahead and share my screen and show you. Sorry, you'd think I would know how to do this by now. Share screen. All right. Can you guys see this? Okay, so just to say that, before I input all the aliquots, I gave some brief instructions, and I said, I want you to help me solve a case. I will present it in aliquots. For each aliquot, provide a problem representation, and second, provide a prioritized differential with a justification, and lastly, provide any diagnostic tests. So then they said, of course, I'd be happy to help. So this is just literally exactly what I just said, and then here's the response. So the problem representation they gave was a 29-year-old man with a history of HIV experiencing frequent watery stools for the past 4 days, which has acutely worsened alongside a history of chronic rectal laceration repair and intermittent incontinence. And then it seems like the differential they have here is infectious gastroenteritis, likely due to HIV immunosuppression, HIV enteropathy, complications from previous rectal laceration and repair, and then medication-induced diarrhea. And then lastly, co-infection with an enteric pathogen. And then looks like diagnostic tests were to perform a stool culture for common enteric pathogens, and then assess electrolyte and hydration status and CBC for signs of systemic infection. And then consult ID.
I'll just share 2 quick reflections. I think the first is it's pretty impressive, the prioritized differential diagnosis. The second thing I think is that the inaccuracy here is in the base rate. I think what's happening with ChatGPT is it's prioritizing and overweighing the immunosuppression and making a mistake that many of us do in real life, which is that we move the spotlight from common to uncommon infections instead of expanding it. And I think that here, I think the most likely diagnosis in all comers is actually the least likely diagnosis ChatGPT is saying. But it probably recognizes that this is in in CPS format, which then makes it very true that you're not going to present a case of E. coli causing gastroenteritis today. And I think calling ID consultation is another kind of thing. Like the vast majority of patients with HIV and diarrhea don't even get admitted, honestly, let alone get an ID consult. So I wonder where this data is coming from. It's probably coming from a bias in the literature of what gets written about, what gets done. But otherwise, pretty impressive, honestly.
And this is only 3.5. All right, let me stop sharing and I will go to the next aliquot. All right. So for the next aliquot, so review of systems was positive for fatigue, a 30-pound weight loss over the last month, abdominal pain, and of course, diarrhea. He does not report any blood in his stool, no chest pain, shortness of breath, new rashes, joint pain, weakness, numbness, or tingling. His past medical history, as I mentioned, is notable for HIV/AIDS. He was diagnosed with HIV 10 years ago, and he has been on and off antiretroviral therapy in these last 10 years. His most recent regimen is Descovy, so antricitabine and tenofovir, and dolutegravir. Though he said he has not taken this medicine in what he estimates to be the last month due to various stressors in his life. He follows with a HIV primary care clinic dedicated to supporting people with unstable housing. He has a history of opportunistic infections, including esophageal candidiasis around 1 year ago. Besides the HIV, his past medical history is also notable for 2 prior admissions in the last year for lower GI bleeding. So during the first admission, which was 1 year ago, he was found, as I alluded to have a rectal laceration that was repaired. During that admission, he had a colonoscopy, which noted moderate colitis continuously from the rectum to the mid-transverse colon. And pathology at that time showed chronic active mild colitis, negative for organisms, granulomas, or dysplasia. So that was a year ago. And then he had a second admission for lower GI bleeding that was 7 months ago, where he was found to have a large rectal ulcer of unclear etiology, and he underwent cautery of that ulcer. Biopsies were taken, and pathology returned as hyperplastic features, ulceration with granulation tissue, and focal area of vasculitis. So that's his notable past medical history. No notable family history. In terms of social history and health-related behaviors, so he was born in San Francisco. He lives in a hotel in San Francisco. His occupation is cleaning, assisting with cleaning at this hotel. He, in terms of kind of drug use, he reports smoking heroin 1 time daily. He said his last use was about 2 days before admission. He reports prior use of injection drugs, but stopped last year due to kind of a scary overdose that made him stop. He reports drinking 2 drinks of alcohol 2 to 3 times per week, and he says that he has not been sexually active over the last year. So his prescribed medications are his anti-HIV antiretroviral therapy, the Descovy and the dolutegravir. But as I mentioned, he has not taken them in around a month. He's also prescribed Bactrim for prophylaxis, but also reports not taking that very consistently, and no allergies. And then I'll give you the physical exam. So his initial vitals in the ED was a temp of 37.4. Blood pressure was 148/80, heart rate 92, and he was satting 100% on room air. In general, he appeared very lethargic, uncomfortable, and chronically ill appearing. When I went to see him, which was actually a little bit after the ED admission, but his eyes were closed during his conversation and just looked very uncomfortable. For HEENT, his oropharynx was clear. He did not have exudates. No thrush was noted, no lymphadenopathy. He did have dry mucous membranes. Cardiovascular exam was no murmurs there. Pulmonary, clear to auscultation. Abdominal exam, his bowel sounds were present, but it was soft, non-tender, non-distended, no masses appreciated. So GU exam, this was performed by the people in the ED. So their note mentioned what appears to be a possible external hemorrhoid or a small red mass that was partially visualized emerging from the rectum. And they reported constant fecal leakage from the anus, which had normal stool color, no blood present or melena. For the extremities, no rashes or edema, and the neuro exam showed no focal deficits.
Oh, wow. I feel like I got a little distracted towards this because it got so interesting, but I feel like this has been Maddie week on CP Solvers with 2 outstanding discussions on Tuesday and Wednesday, and then like a masterclass of a presentation. This is such a complicated case, and I think you're distilling out the key features for us to really study. And maybe I can just take the rest of the HPI and then leave Prof. Rez to mop up my mess because it's tricky. I think there are a lot of, we started off with like simple case of, HIV and diarrhea, and it's such a common complaint that I think you can go down a tunnel. And I think the context that you've provided for it makes it a little bit tricky to know what to focus on. Because I think the additional features you've provided are that he has severe weight loss, he has abdominal pain, he has a history of GI bleeding, which opens us up to 2 different findings. The first is colitis. The second is 3 different findings. The first is colitis. The second is ulceration. And the third is the evidence of vasculitis. So we have 3 sort of objective findings with specific entities: colitis, ulcer formation, and vasculitis. And then we have 2 accompanying syndromes: the weight loss and the abdominal pain. And I think that it's impressive how much of a view we have into this person's illness inside their lumen. And I'm already wondering, based on their weight loss and the fact that they had an ulcer and the fact that they had vascular involvement, what the view looks like from outside the lumen with a CT scan. Because I think that it's impossible to start to generate a robust differential diagnosis without an outside-in view rather than an inside-out. And I think reviewing that data, if it hasn't been obtained, getting it ASAP will be really, really important. But I think if we go to our to a helpful to a potentially helpful framework is to try to simplify this is to say, well, I have inflammation in the GI tract and I have an ulcer formation. Could I just simply simplify the analysis and assume that the ulcer formation is as a result of the inflammatory process in the GI tract? And that's where we go and say, okay, let's go ahead and do that. That's not perfect, but it's a good start. And that's where analyzing proctocolitis, procto meaning the involvement of the rectum, you kind of go and say, okay, I'm going to call this proctocolitis. I'm going to deploy my 4 I's for colitis: infection, inflammatory disorders, ischemia, and then infiltrative diseases. Infiltrative diseases are often malignant, but they can be non-malignant. And in a patient with HIV, malignancies affect the GI tract with a much higher rate, especially lymphomas and Kaposi sarcoma. In terms of ischemia, it would be relatively unusual for patients with HIV to get ischemia, but remember, they have a higher rate of atherosclerotic disease, and they have a couple of associations with vasculitic disorders, namely polyarteritis nodosa, which is classically associated with Hep B, but does have a weaker association with HIV. In terms of the inflammatory disorders, this is where it gets interesting, because you can have a variety of inflammatory disorders directly related to HIV, including one that affects the bowel. It's called Dill's diffuse infiltrative lymphocytosis syndrome. But it's totally plausible that this person has inflammation independent of their HIV. He's a 29-year-old man. Could he have Crohn's or ulcerative colitis? It's plausible. But as Prof. Rez emphasized, the focus initially is going to be on infection. And just because this patient likely has had a workup up the wazoo for infections, including biopsy and histopath, does not mean an infection has been excluded. There are some infections that are notoriously hard to diagnose, including the most recent NAJM CPC a week ago that took quite a bit of histopath to diagnose. So the whole slew of infections that Prof. Rez mentions are still fair game. So what am I doing now? I think that 2 things have changed. This is now for sure a chronic inflammatory syndrome featuring diarrhea. And I think the questions are, is the problem really a colitis? Or is the problem a colitis? And is this an extension of that? And what is the origin of the colitis? Is it intraluminal from an infection, or is it extraluminal from an infiltrative cancer, or a penetration of the vessels causing ischemia to the bowel? So those are the things that I'd be toggling with based on that information, but there's a lot left. And so I'll pass the mic to Prof. Rez to reflect on that and to add anything else that is mind.
Can you hear me, Ravi?
Yes.
All right,
I can't see you
perfect.
anymore, but I can hear you. I don't know where you went.
Yeah, my internet is a bit unstable, so I can't even see the whiteboard or anyone. I actually don't have anything to add to what you said. The only thing that we need to analyze is that mass or hemorrhoid that Maddie commented on. So I think that may make its way into our frame, because if we start saying colitis, ulcer, and mass, the mass may allow us to make tremendous progress in this case in terms of whether we're dealing with an opportunistic malignancy that has now taken on the form of a mass. And we just have to be cautious that because we have one diagnosis, it doesn't necessarily rule out the possibility of another diagnosis because the patient is quite immunocompromised. So for example, the CMV, if this patient had CMV explaining the ulcers, I wouldn't be surprised. And on top of that, they had another infectious process or malignant process explaining the colitis or the mass. So just being open to multiple possibilities and checking your illness script and trying to match it with the problem that you're analyzing. So just because we get CMV back that's positive, we have to pause and say, well, can CMV cause a mass, for example? Back to you guys.
All right, fantastic discussion so far. Let me share my screen to show you what ChatGPT said. All right, can you guys see this? Okay, so this is just me copying and pasting what I said. And then, so their new problem representation is a 29-year-old man with a history of HIV/AIDS, inconsistent adherence to antiretroviral therapy, and a complex medical history, including opportunistic infections and prior admissions for lower GI bleeding. Presents with recent symptoms of fatigue, weight loss, abdominal pain, and diarrhea, accompanied by a possible external hemorrhoid and constant fecal leakage. So their prioritized differential diagnosis is number 1, HIV/AIDS related complications. And the diagnostic test they're looking for is measuring a new CD4 and viral load and looking for signs of malignancy, like you said, KS and lymphoma. Their second differential is IBD, including Crohn's and UC, and it seems like they're basing that off of the colonoscopy findings that showed moderate colitis. And they're wanting a repeat colonoscopy with biopsies. And then they're interested in GI infections. So sending stool cultures, PCR panels. And then they're mentioning hemorrhoids and an anal fissure. And then lastly, malignancy.
Yeah, quick reflection.
Yeah.
Oh, thank you, Maddie. Just quick reflection. I think the issue right now is that ChatGPT is not recognizing that, or maybe it is, and I just didn't read it because I'm using my phone now, that you could have multiple processes happening at once. I think that's very important. And then also making the point that once you identify one diagnosis in such a patient, really asking the question, can it explain all of the problems that need to be explained? So I think that it's making, I know we told it to list the DDX, but it would be nice if you could say, hey, we need more data. Let's, like Robbie said, let's see what's happening outside the lumen before giving the differential diagnosis. But it's still very, very good in terms of what it's considering. I really don't have much to add. I think this is the exact buckets that Robbie and I are thinking about at this moment.
All right. we'll go to the third aliquot. All right. So in this aliquot, I'm going to give some initial labs and imaging. So the initial labs, this was on admission to the ED. The white count was 5, which had a normal differential, 2.78 neutrophils, 1.35 lymphocytes. The hemoglobin was 8.3. Hematocrit was 28, with an MCV of 62, MCH of 18, MCHC of 29, and platelets of 345. For basic metabolic panel, sodium 133, potassium 3.9, chloride 105, bicarb 21, BUN 19, creatinine 0.81, glucose 98, calcium 8.6, mag 1.6. We got a UTOX was obtained, which was positive for amphetamines, fentanyl, and opiates. There was an ESR, which was 130, a normal being less than 15, a CRP of 37, normal being less than 3. And there was a repeat CD4 and viral load, and the repeat CD4 was 58, and the viral load was 550,000. In terms of initial imaging, they got a chest X-ray, which was clear, and they got a CT abdomen and pelvis with contrast that I can actually show you if you're interested, or I can just read the impression. Would you like to see it first?
Yeah, let's take a quick glance. Why not?
All right.
Oh.
All right, can you guys see this? Okay, so I'll just kind of scan through it. All right.
I mean, Robbie, if I take a quick crack, it seems like there is a lot of bowel wall thickening and rectal thickening. And it seemed like there was urinary distension. I don't know if the patient tried to pee or not. And maybe a mass, if you look in the rectum. Like, Maddie, what was their impression?
Yeah, actually pretty spot on. Stop sharing. All right, so I'll give you kind of the more detailed comments in the radiologist's report and then the overall impression. So the report mentioned irregular wall thickening of the right aspect of the lower rectum, extending to the anal verge, suggestive of a mass, measuring up to 6.7 centimeters in length. There was also fluid-filled small and large bowel loops, suggestive of diarrheal states, no bowel obstruction. They also commented on multiple bilateral perirectal lymph nodes, up to 1 centimeter, and enlarged bilateral inguinal lymph nodes, up to 1.6 centimeters on the left. They also commented on a spleen enlarged up to 14.7 centimeters with punctate calcification. So their overall impression was 1, a mass in the right aspect of the lower rectum extending to the anal verge that was 6.7 centimeters, prominent perirectal and bilateral inguinal lymph nodes, and then splenomegaly. So at this point, ID was consulted for recommendations of restarting antiretroviral therapy and for the workup of this mass and the diarrhea. The patient was started on TMP SMX for PJP prophylaxis, and his antiretrovirals were restarted. And then in terms of infectious workup, at this time, blood and stool cultures were drawn, and several studies were sent to investigate the cause of the diarrhea. And I'll pause there.
Our friends, who knew you were a radiologist? That wasn't me. I look how you just like took it in so casually that you just crushed that read. That was so impressive.
I'm definitely this confirms that I am not a radiologist, my friend.
And that was also from your phone.
Yeah, I know, right? That was really cool, Prof. Rez. Nicely done.
So, Robbie, maybe I'll tackle the laboratory data and give an update on the PR and leave the imaging for you to comment on. But I just have to say that like the frame we're solving right now is a patient who has a very low CD4 from HIV/AIDS, about 1 year or chronic history of what seems to be proctocolitis with ulceration, who's now presenting with acute worsening non-bloody diarrhea. And the reason I'm sharing such a frame is because we have to ask the question, are we dealing with acute worsening of a chronic process, or are we dealing with a chronic process that has yet to be diagnosed with a brand new acute process? And of course, in the frame, we have to put the splenomegaly, the lymphadenopathy, and the rectal mass, because that'll help us make tremendous progress. But in my mind, none of the labs were surprising. Like I expected this patient to have microcytic anemia based on the history of blood loss and in the context of the inflammation with the very high ESR. And this is a testament that patients who are immunocompromised or older or don't have a strong immune system, they may not mount the typical fever that we expect to see in the physical exam. So I think the next step is to analyze the imaging and ask the question, are we dealing with a malignancy that has started in the rectum and has spread outward, plus another process that is causing ulcerative inflammatory pathology within that intestinal tract? But Mike, to you, my friend.
Prof. Rez, I really appreciate you like summarizing where we're at and anchoring us in that reality. And I think that the extraintestinal signature of this disease is really, really interesting. But the challenge is not to make the assumption that one unifying entity has to explain everything, and that's the hard part. But I think if you analyze the splenomegaly and lymphadenopathy, you can try to put them in a pattern. And that pattern is essentially probably best referred to as reticuloendothelial activation. And that combination in all comers should make you think of lymphoma, lymphoma spreading through the reticular endothelial system. In some patients, you would also think about autoimmune diseases that do it with sarcoid and Stills being at the top of the list, but those don't merit any consideration in this patient now. Instead, we should probably continue to think about what kinds of infections we should think about independently in the reticular endothelial system, and then say, well, which ones of those go to the GI tract? And whenever you're thinking about infections that go into the reticular endothelial space, they come in two varieties. They come as mononucleosis-like infections with EBV, CMV, and HIV being considerations. So this would all, unfortunately, could be just HIV-related lymphadenopathy, maybe not the splenomegaly. But the most important infections to think about when a patient has chronic reticular endothelial activation are granulomatous infections. And there are so many granulomatous infections that a helpful filter for them is to figure out if there's lung involvement or not. And that's, again, we talked about the importance of thinking about what's outside the GI tract. And now that we've found something, it now becomes even more important to find out, does the patient actually have a portal of entry for many of the granulomatous infections that we would entertain that go to the spleen and lungs? And where do they come from? They mostly come from the lungs, though they can come from other places. As Yusuf reminded us with a great case of disseminated BCG, that it can come from the GU tract, it can come from the skin with sporothrombosis as an example, or Bartonella. But the lungs are the major hotbed for the subsequent dissemination. So now I'm really interested in the chest CT and would not be surprised if it's whoppingly positive with no symptoms, and wouldn't be surprised if it's negative because the patient doesn't seem to have any thoracic symptoms. But if we assume what the mind naturally does is, given no data, it assumes there's nothing to look at. And so if we assume that the patient doesn't have a portal of entry from their lungs, the notorious infection that does this is Mycobacterium avium intracellularly, or MAC, which causes splenomegaly, lymphadenopathy, and strong propensity for the gut. However, even if there is no overt lung involvement, and it's in a patient like this, you have to think about TB. No matter what their geographical exposure is, and living anywhere is enough to have TB. 5% of patients with TB do not have an identifiable geographic risk factor. 5%. It's not an insignificant number. And then histoplasmosis, which also is present worldwide, causes reticular endothelial activation and spread to the GI tract. But I think for me, I wouldn't be thinking about any of this in real time. I'm just sharing these thoughts mostly as teaching points. The next step is to understand the problem. And for me, the next step is what other lymph nodes are involved, and crucially, are the lungs involved or not in this disease process? Prof. Rez, since it's such a rich aliquot, I'm curious if you have any other thoughts to layer on before we learn from the inferior ChatGPT.
Yeah. Well, one thing that I just love hearing the way you speak and the words you choose to say. It's like always poetic, Robbie. For me, the one other thing that's unexplained from a disseminated granulomatous process is this rectal mass, but it could maybe be infiltration, but it seems unusually thick and dense. And we know that these patients are at very high risk of solid malignancies within like squamous cell cancer or adenocarcinoma. So I love the idea of seeing what the thoracic signature is of this disease, if any, but I also would have a very low threshold to biopsy where there's that dense mass-like structure in the rectum, because I'm worried that we're dealing with multiple processes here, and hopefully GPT 3.5 is not worried about that, so we can display our dominance over the machine.
All right, let's see what ChatGPT says. All right, so this is me copying and pasting what I said. And then, all right, so they're saying the clinical picture is becoming clearer. Working diagnosis, HIV/AIDS related complications with a high suspicion of a rectal mass, potentially malignant, contributing to the diarrhea and weight loss. So their revised prioritized differential is number 1, malignant rectal mass, such as anal carcinoma, based off of the CT scans with the prominent lymph nodes, and they're wanting a biopsy of the rectal mass. Number 2, they're saying is opportunistic infections such as Mycobacterium avian complex and CMV. And they are wanting PCR or culture of the biopsy tissue. Number 3, IBD, wanting a colonoscopy. And then number 4, HIV immune reconstitution inflammatory syndrome due to the weight loss and the focal rectal mass. And then lastly, substance-induced GI symptoms. And then diagnostic tests, they're wanting a biopsy of the rectal mass, further imaging such as a PET scan, consult colorectal surgery, continue antiretroviral therapy. Yeah, that's what they're saying. All right. Any thoughts?
Well, I was just going to say it's a smart move on ChatGPT's front to align itself with Prof. Rez's thoughts. It's strategic. I wonder if it heard them before it said that. But I'm glad you literally did it before. That was very impressive. I think that the focus on malignancy is a wise one from ChatGPT, and I think for me, I'm recalibrating my take. Honestly, I think I underemphasize the rectal mass in large part because I find splenomegaly and lymphadenopathy so cool and so intriguing. So there's a little bit of like coolness that like mitigates the focus on the rectal mass. That was a cool like calibration for me. But yeah, we're ready for the next aliquot, Maddie.
All right. So for this next aliquot, GI was consulted at this time, and they performed a lower endoscopic ultrasound and a colonoscopy. So the endoscopic ultrasound showed abnormal lymph nodes in the perirectal region, and they performed a fine needle biopsy of those lymph nodes. And then the colonoscopy showed a single solitary ulcerated mass in the rectum and in the distal rectum abutting the anal verge. Apart from the anal rectal lesion, no obvious colitis or large lesions in the more proximal colon. So biopsies were taken of the ulcerated mass for histology and for microbiologic studies. And then also random biopsies were taken in the descending and ascending colon. And ID had requested that those rectal biopsies be sent for CMV, HSV, and non-tuberculous mycobacteria. So I'll give you some of the infectious studies that returned at different points, but I'm just going to give them all to you now. So blood cultures were taken at the beginning, which were negative. The stool GI pathogen PCR panel was also negative. I can read out some of the many bugs that was on if needed. For example, like Campi, Salmonella, Vibrio, Yersinia, E. coli, Shigella, Cryptosporidium, Cyclospora, Entamoeba histolytica, Giardia, adenovirus, norovirus, things like that. C. diff toxin PCR was negative. HSV 1 and 2 PCR was negative. Stool O and P was negative. No ova and parasites seen, including Cryptosporidium, Cyclospora, and Isospora. Cryptococcal antigen was negative. TB testing was negative. They got a CMV IgG, which was greater than 10. And they got a CMV IgM, which was 37.9, normal being less than 30. And I'll pause there.
Yeah, I'll just reflect real quick on the very thorough workup here, which I think in terms of stuff that would still be helpful would be, of course, syphilis, to think about syphilitic proctitis, though. And lymphadenopathy is a common feature, though going to the spleen would be unusual for syphilis. And then an infection to think about very importantly, that's getting more and more recognition is a chlamydia infection called lymphogranuloma venereum, or LGV. It causes severe ulcerations in the rectum and lymphadenopathy, and in a fraction of patients can disseminate all the way up into their pericardium or even their brain. So I think that would be an important test to get. Yeah, I think everything else still stands. I think this aliquot was really focused on the infectious stuff, and the tests here are very informative in their negative predictive value. CMV can only be diagnosed really on histopathology. A serum PCR can be helpful, but if negative, doesn't exclude compartmentalized CMV disease. So here, I think we made a little progress in making the common things not being at play here with the stool PCR. I think that a syphilis and an LGV would complete the STI workup. What are your thoughts, Prof. Rez?
And just to, I just want to say that the LGV and syphilis testing was negative. Just wanted to add that data.
Yeah.
So Robbie, my thoughts are this can't be syphilis or LGV. Oh, okay. So the only additional thoughts I have is that I really feel like, and I would love your thoughts on this, Robbie, that I feel like there is a disseminated granulomatous process, or there was at some point. Why? Because of the calcification in the spleens and the active splenomegaly. It just makes me worried that there was some, prior or active granulomatous infectious process. But with regard to the mass, and I think this is a separate diagnosis, though the mass could be involving the colon, and we'll see what the lymph node shows. There's two key features about this mass. One is the tempo at which it's grown, because remember, they had not seen it previously, or it seems like it's rapidly evolved, which is not consistent with your typical adenocarcinoma. And then the second characteristic of this mass that's very unique and interesting is the ulcerative nature. And I was just doing this in real time, Robbie, like, why do we have ulcers? If you think about ulcers on the lower extremities, it's often either vascular, whether it's venous or arterial, or neuropathic. And why do neuropathic ulcers occur? It's because of repetitive trauma. In this patient with this mass and the ulcer, I'm actually worried about it rapidly growing and causing vascular compromise, leading to decreased perfusion and ulcer formation. So I'm really worried, could this be something like a sarcoma or something that's going aggressive and forming ulcers? I would love your thoughts on that, RG.
Yeah, no, I completely agree with you, Prof. Rez. I think the tension here is, the rapidity and the rapid growth of this lesion is certainly notable, and I completely agree with you. All those cancers could be at play. And the parallel question to consider is the patient's immunodeficiency another culprit region for a cancer also behaving unusually and growing? And I think that both those things are at play. And I think that in this patient, you need tissue for sure, but as you said, could this be rectal cancer or a sarcoma or a rectal lymphoma with MAC? It totally could. And I think that the impetus to try to tie this together has to be negated by the idea that multiple things could be at play. And just to mention it out loud, I think if you find, how could this rectal mass be causing the colitis? And there is a mechanism by which a rectal carcinoma causes a horrific diarrhea, and it's called McKittrick-Wilcox syndrome, where patients with a rectal adenocarcinoma have a paraneoplastic process that they have a lot of diarrhea. And so the rectal mass could account for all the colon findings, because if it turns out to be cancer. So honestly,
How do you spell that, my friend?
Oh, I can't tell you how to spell it. I'll text you afterwards.
All right.
Yeah, by the way, it's really interesting. It's the only way that you can have diarrhea causing metabolic alkalosis, which is a very interesting and rare phenomenon. But that's a conversation.
Wow.
But yeah, I think you need to biopsy the mass. I think it could be anything. I think it could be any cancer. And just recently,
Yeah.
the NEJM images had a fascinating case of testicular tuberculosis that looked like a testicular mass. So granulomatous infections can mass forming lesions. So would I be shocked if this mass is just stocked full of granulomas and has TB in it or MAC in it or histo in it? I would be surprised, but I wouldn't be floored. So yeah, you gotta take. Oh, thanks, AMK. AMK spelled it for you, Prof. Rez.
Thank you, AMK.
Yeah.
But I just wanted to quick reflection. I love the point you made about just common cancers being more aggressive. It's almost like common infections being more aggressive in patients with. I never thought of that, but that makes a lot of sense without the immune system intact to surveil and keep it suppressed.
Really intrigued, Prof. Rez. I'm curious what our arch nemesis.
Yeah, let's see what this.
I accidentally said arch emesis, by the way. Don't
worry, you got the McKittrick-Wilcox right. That's all that counts.
All right. The clinical picture is becoming more precise, they say.
What?
That's what they say.
Okay, fine.
Working diagnosis: rectal mass with high suspicion for malignancy with the possibility of concurrent CMV infection contributing to symptoms. Revised, prioritized DDX. Number 1, malignant rectal mass. So that's still their number 1. Number 2, they're saying is CMV infection, given the elevated CMV IgM. And they want biopsies. Number 3, IBD. Number 4, other opportunistic infections, just in general. And they want rectal ulcer biopsies, continuing antiretroviral therapy, and that's about it.
Quick reflection here, Maddie, is that it's doing a great job. Now it's considering multiple diagnoses instead of one. The only lesion in its thinking is not thinking of granulomatous processes. Like, I think that's very important with the history of prior calcification, the splenomegaly, the colitis, and even the rectal mass. So I think so if I was using this in real time, I would ask it, what about granulomatous processes? Could this explain it? That's how I interact with this platform in real time. And it's really good at communicating. It'll be like, oh, that's an astute observation. You're right. It could be this, and that.
Oh, sounds like it's polite. All right.
It is.
So for the next so this is going to be the last ALCOP before the final diagnosis, and it's going to be the pathology. And I actually reached out to the pathologist and got some of the slides. So
Wow.
Reza, you're a radiologist, and I think maybe you're a pathologist too. We'll see.
Bring it on, Maddie. I'll start it by saying this is a patch specimen. H&E stain at 10 times magnification.
So this is the slides I'm going to show are specifically pathology from the mass. All right.
Or maybe it's a GMS stain looking for a fungal. We'll see. Let's look at the slide, my friend. So Rob, this is the one I put on the pathology hat. And really, I think what you're seeing here is what looks to be, first of all, some hyaline and like thickening. You can see that in between these blue cells. And it almost looks like we're looking at a granuloma, like there's an area that's protected from these cells infiltrating. And I would have to ask Rabih to see,
Oh,
you know,
no,
for CMV, we look
no,
for like these intranuclear inclusions. If Rabih sees anything
no.
on that,
Rabih is
in
not
that
here.
sample.
I see nothing of anything that I can interpret. This is like me looking at a language I don't understand. It looks bad. That's all I can say. I'm so
Oh my gosh. And
I
one last thing I want to say with
this is
GPT-4,
one
you
of
could
the
actually, yes.
if that's
That, by the
yeah.
way, that is helpful. But with GPT-4, you can actually put the image in and be like, hey, what do you, I don't know how it would perform, but we'll see next time. But Maddie, break it down for us, please.
Okay, so there are like two other slides, but yeah, I'll read the things. All right, so the fine needle aspiration of the perirectal lymph nodes from the endoscopic ultrasound. So that aspirate was reported as hypercellular with lymphocytes and mixed atypical inflammatory cells. But going to the pathology, so the colon mass biopsy demonstrated ulcerated mucosa with scattered large cells, often in the endothelium. And then these cells contained brightly eosinophilic intranuclear and cytoplasmic inclusions, no features of dysplasia or carcinoma. And then bacterial, fungal, and AFB cultures from the rectal tissue was negative. And I'll just pause there because that's the last bit of information before I say the final diagnosis.
So Rabih, the only thing I don't know what eosinophilic intranuclear, the only thing I associate with intranuclear inclusions is the herpes viruses, CMV. But I'm curious if anything of that path is a buzzword for you.
Yeah, no, I have that association too, Prof, as of those intranuclear inclusions being HSV, being herpes viruses. And I guess the question is, which one would we prioritize? And I think it's interesting that this has a vascular, that a lot of the nuclear inclusions are in the endothelial cells. And I think it's a great reminder of just the significant overlap of herpes viruses and the vasculature. And we all, if you've spent some time on VMR, have heard this kind of conversation. Oh, HSV encephalitis, what does the LP look like? It's hemorrhagic, reminding you of HSV's propensity to cause bleeding and to cause vascular involvement. What is the risk of a contralateral stroke in a patient with this V1 zoster, VZV? It's high in the first 3 months. Why? Because of the overlap of zoster with vascular lesions. In fact, there was a time when I was following the literature closely and they thought that VZV was a trigger for giant cell arteritis, and that's actually been since disproved. But I remember following that closely. And then CMV and the overlap of CMV and the vasculature is also extensive. It actually is implicated in allograft dysfunction. When patients get cardiac or renal transplants, they find CMV in their vessels, and that is implicated in allograft failure. So I think the overlap of intranuclear lesions and vessels is a really herpes virus one. And I guess, Prof, it's a question of which one we'd prioritize. Are you thinking one or the other, or where's your head at with which one you're?
You know, quite honestly, like I think just based on this is just based on my experience. Typically, CMV ends up being the culprit. But I love the fact that some of these herpes viruses, like EBV or HHV8, are also associated with malignancies. So we had no evidence of cancer here. So I would deprioritize those. And it would be CMV or HSV. I would tend to lean towards CMV based on the colitis picture. And then the splenomegaly. But I still think he had prior granulomatous disease with a calcification in that spleen. I would send the CMV. I think we did send the CMV PCR, if I'm not mistaken, off the blood. But even if it's negative, it doesn't rule out, as you mentioned, Rob, the actual CMV infection. You need the histopathology. So at this point, we would further analyze that with some special tests or stains or stuff to see if it is, in fact, that. Your thoughts on that, RG?
I completely agree, bruv.
And bro, this is where the AI is going to be better than us, bro, because they can take those like terms that Maddie used and like search all the data and say like all the diagnostic possibilities in a high base rate, bro.
All right. Reza, can I just say that before I read the path report, I think you said the word intranuclear inclusions. Anyways, I think you said that.
I was just throwing out terms based on what we did say it. We were worried about granulomas and CMV, so we said both.
All right, let me go to ChatGPT. So, I just copied and pasted this. So they're saying that the working diagnosis is CMV infection, given the presence of, they interpreted those kind of what I put there as CMV inclusions. So their DDX now is CMV colitis as number 1, given the intranuclear and cytoplasmic inclusions. And then second is anal carcinoma, though recognizing the absence of dysplasia or carcinoma. Third is just a general inflammatory response. So basically they're saying they should be treated for CMV colitis.
Either we're both sinking or we're both cruising. We'll see what happens.
All right. So yeah, so basically the intranuclear and cytoplasmic inclusions on pathology raised concern for CMV. And they did immunohistochemical staining of CMV, which was positive for organisms. So let me actually show you the pathology slides again. It was pretty cool. Our team went to pathology, which I had never done before, and we sat under the microscope and looked at this stuff. And it was funny. The pathologist was like, "Oh, do you see it? Do you see like the intranuclear and cytoplasmic inclusions?" And I was like, I don't know if I see that, but I think this is what they were talking about. So I think they're saying this was like a CMV inclusion with red cytoplasmic granules. It's a little hard to see from my opinion. This also apparently showed CMV inclusions, and then this was the CMV immunohistochemical stain, which is kind of interesting. But just to kind of wrap it up, so basically immunohistochemical staining was positive for CMV, and then given that this was an ulcerative mass, the team was calling this a CMV pseudotumor just because it was like forming in this mass-like structure. And then, so for the CMV kind of colitis and pseudotumor, he was seen by ophtho for a fundoscopic exam to rule out CMV retinitis, which was negative. He was treated with ganciclovir with planned transition to PO, valganciclovir, and the plan was to kind of repeat imaging at that time to see if it would fully resolve with the antivirals or if there was a need for like surgical intervention too. And then separately, so I guess to kind of give a summary of like what happened to the patient, he unfortunately self-discharged because he needed to attend to some things outside of the hospital. And there have been a lot of kind of really amazing attempts to try to get him back into care, but unfortunately he hasn't had a follow-up appointment yet. Then when I checked, it's just a few days ago, the microsporidia PCR also returned positive. So the ultimate final diagnosis was the CMV, colitis in this mass-like structure. So CMV pseudotumor with microsporidia that was potentially contributing to this acute diarrhea. Yeah.
Hey, that was just so expert.
I just have one quick comment
Go ahead,
to say. Oh, thanks, Roy. I just wanted to say thank you, Maddie, for bringing the images. That takes so much more effort, but it was really cool to see those slides and be better for the next one. But thank you for going above and beyond for this case.
Yeah, I could agree more. I think it was just so well presented, and honestly, the images make it like feel like a publication, which is really, really cool. How did it feel for you? What was it like to be part of this journey and to be part of it as a consultant, and to yeah, just share with us what it was like to take care of this patient, if you don't mind.
Yeah, it was. So I was on ID consult services. So that was kind of the context in which I saw this patient. And I learned so much. I mean, I think we got involved at the very early beginning when it was like, workup for diarrhea and immunocompromised hosts and advice on restarting antiretrovirals. And I think one interesting learning point for me was about CMV serology. So like the elevated IgG and IgM came back like pretty early on. And so the primary team reached out to us like, oh, like, do we need to start treating for CMV? But it was just really interesting to learn that the serologic tests really don't have a significant role in diagnosing CMV disease, especially in immunocompromised patients. Like they can just be elevated for many different reasons and you really need pathology. And it was just, I think with the lymphadenopathy, as you were saying, a lot of the team was really concerned about malignancy. And so we were all very surprised when this was CMV. And I kind of looked up CMV pseudotumor because that's the term people were using. I'd never heard of it, but there are like many reports. Yeah, it was just really kind of, there were so many different teams involved. And as I said, it was really cool with our team. We like went to pathology, looked under the microscope, which I'd never done before. Like we're talking with the radiologist about any advice any like insight they had on what the mass represented. So there were just so many teams involved, and also just like the primary care team was involved to try to kind of get this person back into care. So there's like so much effort went into it. And it was, yeah, I just learned a ton kind of going through this case.
And he disseminated that knowledge far and wide. It was just such a cool case. And to remember that infections can form mass-like or mimic malignancies is just a really, really cool reminder, let alone everything else that Prof. Rez imparted us his wisdom today. Unfortunately, I have to leave now to make it on time for work. So I will pass the mic to Jimena for teaching points. And Maddie, I made you the host, so feel free to end the meeting when you're all done. Bye.
Well, first of all, thank you to everyone for this amazing case. I might be a little bit biased because I love ID, but Maddie did a fantastic job presenting the case, and the discussion was very rich. So I'm going to take you all to the teaching points of today. So we got to remember that patients with HIV are at risk of opportunistic infections, but also common infections that can be presented more frequently and more severely. We also got to remember that the nature of HIV can impact on the host immune response. So it's easier for us to classify the diarrhea between inflammatory and non-inflammatory and just take that as a starting point. In this case, at the beginning, we were considering herpes, CNV, non-tuberculous bacteria, parasites, Cryptosporidium, especially because he had a very low CD4 count. With this case, also the inflammation plus the ulcer was making us think about if the inflammation was the real cause of the ulcer or there was another underlying process. We were evaluating those possibilities. Also, we got to remember that GI malignancies affect more often patients with HIV, especially like Kaposi, like everybody was mentioning in the chat. And also remember that inflammatory disorders can be separated as either associated to HIV or other common disorders. In this case, we also were thinking about infections, and it's helpful to think about infections that are usually difficult to diagnose. If we are thinking about them, we got to push a little bit more because we already know that they're difficult to diagnose, and also frame this colitis as a process being intraluminal versus an extraluminal. We also saw that this mass was raising suspicion for opportunistic malignancy, and in the context of HIV, we got to remember that these patients have a higher incidence of this malignancy, so it should always be considered and evaluated. With patients with low CD4 count, it's also helpful to have just multiple possibilities in our framework. Is this a syndrome causing all of the manifestations that we're seeing, or there are multiple disease processes happening at the same time? It's also helpful to think about if it's an acute worsening of a chronic process versus an unknown chronic process with another acute problem. And with this patient specifically, due to the splenomegaly and the multiple lymphadenopathies, we got to consider an infection in the reticuloendothelial system. If we're thinking about acute infections, we can remember mononucleosis or CNV versus other chronic granulomatous infections that can be either TV or histo. And particularly in this case, it was helpful to think of the overlap of that those infections can go to the GI, and also think about the possible portal entry to also guide our diagnosis. Another thing that we talked about in this case was a syphilitic colitis and a chlamydia infection that can be disseminated from the rectum. Those were possibilities that we were thinking about too. And also this pearl that they gave us that a CMV PCR does not rule out the disease. We just need to have the histopathology evaluation. Another pearl that they gave us was that the evolution of the mass in this case was faster than expected, and the presence of the ulcer, it also made us think if either was a vascular process or a neuropathic process, and thinking about how HIV can contribute to cancers behaving unusually. And almost finishing here because we had a lot of teaching points. They gave us this amazing pearl, which was the McKittrick-Willox syndrome that includes a colorectal tumor with chronic diarrhea and electrolyte imbalance. Thanks for that, because I didn't know about it. And lastly, we got to remember that herpes virus, like zoster and CMV, can overlap with vasculitis. And that's all for today.
Jimena, oh my gosh, that was an incredible summary of the teaching points, and like more than an hour-long session. There was so much, and you condensed it beautifully. So thank you so much. All right, everyone, have a great rest of your Friday, and see you next time.